Welcome, everyone. We'll just take a couple of seconds to make sure everybody's managed to transition in from the lobby, and then we'll get started. Hello, and welcome to the Center for Health Design's Research Corner, Ask the Author. Thanks very much for joining us. I'm Alan Card, a Research Associate for the Center for Health Design, and I'll be your host for today's session. Before we begin, I'd like to thank the Health Environments Research and Design Journal for providing free access to the articles we review. If you haven't already done so, we recommend subscribing to HERD. There's a discount code for attendees to receive 20% off a subscription using the code HERD20. That's HERD20. I'd also like to say thank you to our Research Corner sponsor, PatCraft. The purpose of the Research Corner Ask the Author is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes and to apply it in the real world. Continuing education units are available for this webinar from the AIA and from EDAC. To receive credit for your participation, you can download the forms at any time by clicking on the Show My Media Library icon, which is located on the top toolbar where the red arrow is pointing. You'll have access to the AIA quiz, the EDAC form, and today's presentation slides. To download a file, click on the green arrow next to the file. When you've finished, click on the double right arrow in the top left corner of the media library. The library will close and the slides will refill the empty space. For EDAC credit, complete the verification form and retain it for your records. You'll need to submit the form to CASEL Worldwide at the time of your renewal. For AIA credit, complete the verification quiz, purchase a CEU management fee for $10 from the CHD store, and submit the verification form to Catherine Anchetta. She'll upload the credits to your AIA account. You'll find Catherine's email address included on the form. I'd like to take a moment to review how to use the chat feature so that you can ask questions or submit comments on what you hear today. This is kind of the central piece of the Ask the Author event, is the ability to talk with the people who are behind this interesting research that you're learning about. As shown on this slide, just type into the chat box where the red arrow is pointing. Be sure to chat your questions to all so that all attendees on today's call are able to see your message. If you're having any technical difficulties, please type your issues to moderator in a private conversation, and we'll see how we can help. I'd now like to introduce you to the authors of the article we're discussing today, Dr. Arsalan Garaves and Dr. Kirk Hamilton. Dr. Arsalan Garaves is an architect, interior designer, researcher, and educator. Arsalan has more than a decade of experience in design and conducting research regarding the impact of environment on behavior in both the United States and Middle Eastern countries. After years of experience in designing and planning different healthcare facilities as a registered architect and interior designer, he started doing research in the area of evidence-based design. Arsalan's work brings together the possibilities of cutting-edge layout design with considerations of human behavior and environmental psychology. His academic research has been published in multiple peer-reviewed journals, including Applied Ergonomics, Environment and Behavior, Indoor and Built Environment, Health Environments Research and Design, and Facilities. Also, Arsalan has presented widely at different conferences on topics including visibility exploration, spaces syntax, safety, wayfinding, lighting, and environmental psychology in different healthcare and higher education facilities. In the last few years, Arsalan has concentrated his research and creative work on exploration of layout design in different facilities and its impact on occupants' behavior. Garaves joined the Southeastern Missouri State University in August 2017 as an assistant professor. Dr. Kirk Hamilton is the Julie and Craig Beal Endowed Professor of Health Facility Design at Texas A&M University, where he has taught healthcare design at the graduate level since 2004. His academic research is about the relationship of evidence-based health facility design to measurable organizational performance. His 5-year professional Bachelor of Architecture is from the University of Texas in Austin. His master's degree in organizational development is from Pepperdine University, and he completed a PhD in nursing and healthcare innovation at Arizona State University, studying nurse movement patterns and interaction with objects in the ICU patient room. A fellow of the American Institute of Architects, he is board certified by the American College of Healthcare Architects with 30 years of active practice prior to joining Texas A&M. He is only the second architect to advance to fellowship in the American College of Critical Care Medicine. He is a founding principal emeritus of Houston's WHR Architects, now EYP Health, with healthcare projects in 20 states and 8 other countries. He's received the Lifetime Achievement Award from ACHA and the Changemaker Award from the Center for Health Design. Kirk is also a founding co-editor of the peer-reviewed interdisciplinary Herd Journal, now in its 12th year. Thanks very much to both of you for joining us.
Glad to be here.
As I mentioned, we're hosting this... Oh, thank you, sorry. As I mentioned, we're hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article, The Impact of Visibility on Teamwork, Collaborative Communication, and Security in Emergency Departments, an exploratory study, is published in the Health Environments Research and Design Journal. On today's call, we'll have an active discussion about different key factors in your study. And without further ado, I'll turn it over to the authors.
Great. Thank you, Alan. We appreciate the opportunity to discuss this. It should be clear that this is the work that Dr. Garaves has done as part of his dissertation. But what we're going to be talking about today is essentially the pilot study which led to the majority of his work. So this research explores the high visibility issues associated with an emergency department, the ability to have staff see one another, and the impact on their teamwork and their communication. He is working with the idea that this kind of communication improves the quality of the care delivered, and it can enhance the way security is perceived. So bear in mind, this is an exploratory study. It's looking at this issue of how one can see each other within this physical environment. The issues associated with teamwork and communication and security have been borrowed from a variety of disciplines. So work in psychology, medicine, and nursing were referenced in order to develop the basic premises of the research study and the research questions. So there is another paper that Dr. Garaves and I and Dr. Patti from Texas Tech put together as a review of the literature and associated with the same concepts. And what was discovered is there's not a lot that has been published that relates these physical factors to communication, teamwork, and security. So what's important is Dr. Garaves' definition. He declares that visibility is the level of visual connectivity among different points within a defined enclosed environment. The defined enclosed environment here is any of the emergency departments under study, and the connectivity he's using software to determine where the visibility from one location within the plan to another is possible. So the objectives were to investigate how this visibility issue related to the other issues of teamwork, communication, and security, and he wished to explore some strategies to see if they could reduce safety and security problems, improve teamwork, improve communication. Well, the methods of his study, it's a qualitative study. It's not a quantitative study. It's a qualitative study which is often used to investigate something that hasn't been studied before and will lead to the potential for other deeper levels of investigation. So it's a qualitative study that's looking for the impact of visibility on these other issues, and part of the way in which it was performed is he conducted one-on-one interviews and that he performed field observations. So at this point, I would like him to take over and share with you what his findings were.
Thank you so much, Dr. Hamilton. As Kirk mentioned, this study was qualitative, and I just want to talk a little bit about settings and sample. So before moving forward, I just wanted to give you that how we defined visibility and how we wanted to act upon our definitions. So we used the software depth map, and we used the methodology and the philosophy of space syntax, and we called it morphology analysis as it is in the literature. In this case, the morphology analysis typically divides up the plan into small pieces, which is a grid 1 foot by 1 foot, and also calculates the visibility factors of each point according to the level that it can be seen from other locations and can see other parts. And as you see on the bottom right, you can see that the places that were more saturated, that meaning the places that can be seen from other places and can see other places, are saturated and are shown in red. And as you see on the corner of that, again, bottom right diagram, you can see that the places that are pretty bluish, they are the places that are more segregated. So this software helped us, instead of sitting over there and counting the visibility values of each location, helped us to understand which places are more visible and which places are less visible. And also, according to graphs that this software provides, it gives the information to the researcher that and has some calculations and gives the potential to understand the overall value of visibility in each enclosed environments. So here we had just one site over in this pilot study, but you can imagine for the main study, which we had 4 sites, we were able to compare different sites according to the levels of visibility based on the findings of depth map software. But also we had field observations, and you can understand that since we had another measurements about visibility, that gave us the opportunity to understand which places are more visible, and based on our ideas and thoughts, according to the literature, we understood that if I would observe from those spaces, the potential to capture more minutes of communication and teamwork, and also to see the overall function of the department would be higher than other places. So as you can see, in those areas, I'm sorry about the lighting, automatic lightings. So you can see here, that gave us the idea where I should stay and observe the whole environment. So moving forward, those are some terms and data collection ideas. So I have to clarify and give you the idea that what we mentioned and in the research about teamwork, collaborative communication, and security, because we wanted to understand what would be the perception of the nurses and physicians who have the ideas about their design, but also we wanted to understand what other the audience of our research would understand from that. And also we wanted to see if we would measure the same thing that we consider in our research or not. So about ISOVIST, which was one of the factors in overall visibility in the depth map software, is about the ratio of visible area from a given point to the whole area. So you can imagine each point has a specific value of ISOVIST, and the whole department would be categorized as the mean or average of all the locations, and gives us the idea that how visible the environment can be. The other part is about teamwork. Here, the focus of this study was about only medical teamwork, and it was about the provision of requirements, assignment of responsibilities to staff, and coordination of care processes. In this case, we just wanted to focus on only medical staff and their teamwork, and I will define those in a future slide. But also, I talk about collaborative communication, meaning a sharing of patient information and what care is planned within a time interval when the staff are interacting face-to-face in order to achieve the defined goals. And also, I think it's clear that we wanted to talk about communication, but this is specific about staff-to-staff communication, also about the patient issues. So we didn't talk about social interactions and other pieces of communication, which is huge. Here, we wanted to focus on very specific idea to give the audience the idea that we're just exploring and deep down on one of the ideas. And also security here is the protection of people and property, and of course it's a subset of safety in healthcare delivery, and we know that if safety or security would be bad in some places, probably the efficiency and healthcare delivery would not be the best. So over here, I just want to give you about our observations. So we had 6 hours of observation here during the busiest hours. So of course, we just wanted to first of all check the protocols and logistics to see how we are going to do it in the main study. And also, we just wanted to do that during the busiest hours. And it was important for us to see if we can capture as much as we could, because during the busiest hours, according to what nurses mentioned, that's the biggest issue. So when the department is not busy, I think they have the least concern of communication and teamwork because everybody's available and they don't have so much to do with it. And also about security, many of the events happen during the time that the staff are not busy and they can't supervise. And I think that's going to be an issue that we wanted to conduct these observations. According to the literature, according to Spradley 1980, which is based on naturalistic inquiry and the whole philosophy of quality of research, which is based on knowing the real-life experience, we had to focus on 9 different categories of observation. So we checked settings, activities, actors in the setting, the situation of the actors in the setting, objects, time, goals of behaviors, and emotions and feelings. And I think that worked a lot. That was perfectly for our study because we wanted to focus on 2 different types of information. On one side, we wanted to explore the environment, and specifically in this case, visibility. And also we wanted to explore the other behavioral factors, which was communication and teamwork and security. Also regarding the interviews, so we wanted to find out some nurses and some physicians who have a lot of information about visibility and working and teamwork. So this is why we just checked the whole department. After conducting those observations, we contacted the management and asked them who are the most experienced ones and who were willing to be included in this study. Also, we can imagine that they had some inclusion criteria to work in ED for at least 3 years, and in that specific ED for at least a year. So we had the ideas over there. So we interviewed with the people. We conducted those interviews and transcribed whatever we recorded, and also we had to analyze the data. So we put the similar ideas together and coded the process. And also that coding helped us to understand, to cluster the related ideas together, and also had some subcategories to explain the ideas. And also regarding the observations, first of all, we checked who can see who and recorded that process. And also I took some notes and I had the analysis of the notes afterwards. So in order to clarify what we exactly did, this is the conceptual model of the research. So on the left-hand side, which is highlighted in dark gray, you can see the independent variable. So here we had 2 different ideas. We had general visibility, which was from depth map or isotest. And also we had the staff-to-staff visibility or between the staff visibility, which was achieved from our observations and understanding who can see who. And as I mentioned, we just focused here on medical teamwork and communication, which included nurses and physicians. On the right-hand side, you can see the dependent variable, which was teamwork, collaborative communication, and security as different variables. And also in between, you can see the potential confounding variables. So of course, in any environmental behavior factors, we can't segregate the parameters and only focus on those. So we have to consider other factors. And here, we found lighting and acoustics and ED size were important in terms of environmental factors. And also there were some non-environmental, which was staff job experience. And here, I just want to share some of the ideas with you about the findings and discussion about what we found and how the ideas were triangulated and were repeated. So here on this table, you can see we found some 5 themes. Themes, again, I want to describe that they are related ideas together, and whatever the ideas will be repetitive, will be saturated, they will be considered themes. So overall, we had 5 different themes. The first one was about importance of visibility. The second one about different types of visibility, as we discussed. Who were the people who are visible to each other, and also what types of visibility overall we have. And also we found some ideas about the importance of teamwork and communication. And then number 4 is exactly the relationship between visibility and those 3 factors, as we discussed. And finally, we had other factors in design considerations. As far as the sub-themes go, we talked about the importance of visibility, but in those interviews, they were repetitive ideas about what we are talking about. So face-to-face visibility versus technology is talking about the nurses mentioned that they still want to see each other even though technology has resolved many issues. Or, for example, visibility and distraction, they mentioned that if they would see their colleagues, there is a less chance to be distracted by other events and forget about communication. Or talking about patient assessment and comfort, that was really highly emphasized. Or also about the staff-to-staff visibility, they mentioned that they want to, like, it's highly recommended for them, especially from the physicians. They think that they want to see the nurses because the nurses are the people who can touch the patients and can do many things for them. Or also they think about the new nurses and old nurses and the stress level because, of course, the old nurses may need less help than the people who are new to the department. And also there were three different major of the ideas in different relationship between visibility, and they all mentioned that, yes, they think that it's very important. And that helped us a lot to understand, okay, we are on the same page. The perception of the designers are the same as the perception of but the perceptions of the nurses in terms of importance of visibility. So that was the discussion about the interviews. When it comes to the observations, I saw that the trauma and psychotic patients were the major concerns of nurses in terms of supervision and having visibility. And also we talked about the assessing nurse-to-nurse visibility was challenging during busy hours because when the department is getting really busy, it was very hard to find them in public spaces on corridors because they were with the patients in the room. Versus the times that were not really busy, and there was a lot to see in the department, and I could capture a lot of communication. But also, there was a big concern about controlling the door of the entrance of ED from both patient's entrance, walk-in entrance, or ambulance entrance, because they just wanted to see who comes in and out, and especially about the rooms, they were so concerned. And also, we found that the psych patients are a big concern in ED, and they think that they should be highly visible, and the nurses who are taking care of them should be visible from their colleagues. So, regarding the conclusions here, I just want to talk about how the ideas supported each other, both in interviews and observations. And we found that there's a remarkable value in the interviews that we found that nurses and physicians, they think that greater visibility would improve their teamwork and communication. And also this was supported by on-site observations that they can see that value. And also there were some other potential values in visibility that nurses and physicians, they have less distractions when they have visibility, and they can facilitate the patient assessment and enhance comfort levels and reduce the stress levels of the nurses, because if they need something regarding a patient, they could have easily find their colleagues and find out the way that they can be helped, and they can easily get more help and more support. And also, we just wanted to compare the findings of the study with what was existing in the literature. So many of the thoughts were repeated and supported by this pilot study. And also, we had a chance to explore and see how they are limited and how they are closely related to each other. And also, we can imagine that those ideas were mentioned, but that was not the focus of those studies versus this study that we did, which was really focused on those three factors majorly, even though other ideas came up and nurses mentioned, and we quoted them and we reported them. But also you can see some of the ideas were supported. For example, communication, of course, in this study was really supported when we understood, okay, for next step, which is going to be more quantitative and mixed methods, we understood that that's a significant, and we have to explore the ideas and thoughts. And of course, some of the ideas were not supported because the focus of this study was really exactly on the ideas that I discussed. So, of course, we wanted to have some nuggets and some of the ideas to our audience, especially from both parties, from designers from one side, and also healthcare providers and nurses and physicians. We wanted to give them some ideas over here to give them the major things. But before moving forward, I just want to give you that this pilot study had some limitations. And you can imagine this was only a pilot for the main study, so we had a limited number of participants. So we wanted to get the clarity of the questions, clarity of the methods, and how the logistics works. Of course, we did a few changes and few adjustments for the main study. but also we had limited hours of observation, and my committee and I, we worked a lot on that to see how we can make the observations work better. And also we had a variety of covariates that we didn't measure for the pilot study, but we considered them for the main study, and we had a chance to understand them. So this study, as I mentioned, from one part was for the healthcare designers and planners, and since Dr. Hamilton has been in this field for more than 3-4 decades, I just want to hand it over him and let him talk about design implications and how the designers and architects and planners can use this type of info.
So thank you, Arsalan. The implications of a study like this basically support a lot of the assumptions that, as designers, we have thought might just simply be common sense. The idea that if you can see your colleagues, if you can see the patients and what is needed, you can jump to help somebody. This is part of why we have seen over a long period of history many emergency departments are organized in what Frank Zilm calls a fishbowl, that has just enormously easy ability for people to see each other and see what needs to be done, see when problems arise, and so on. So does this study support that? Absolutely. This study is one more of many potential studies that validate the idea that in emergency departments we need to be able to see what's going on and be aware of what's happening. We talk about awareness when we're talking about the tasks of nurses. You could take the implications of visibility in this study about emergency departments, and you might say there are some analogies with critical care that would suggest you could interpret what has been learned here and use it in other settings. We know that the visibility across from one staff member to another, it impacts the teamwork, and it has the potential to improve efficiency. If you can see people and quickly signal or say what needs to be done, then you're able to work more smoothly than if you have to call somebody on your Vocera telephone, or if you have to somehow press the call button or the code blue button or some other device. The considerations that he has examined that included things like the auditory levels and other lighting and other things are things that impact whether or not this visibility is useful. They are strong suggestions of what future studies might examine, and it allows for the conclusion that if you have done it properly, we're going to promote communication, and that's going to be helpful in an overall sense. So another aspect of it that relates to security and to the frequency of remarks from people being interviewed about the psych patients is that with high visibility, the potential for aggression and for other adverse events gets to be lowered. So all in all, the implications here are very strong for designers, encouraging them to think in terms of the way that DefMap software analyzes the space. It could be that if you produce a diagram for your future plan that uses that kind of thinking, if not actually using that kind of software, you may be able to produce stronger and more effective designs. I think we are able to recognize that this is just a pilot study. It's an exploratory study, so take it for what it is. Don't rely too much on it. It was a very strong support for Arsalan's premise that ended up in his main dissertation, and there are ways for you to actually read his whole document. It's available, I think, on ProQuest. So we're happy to talk about whatever has come to you while this has been described, and we look forward to having conversations that may extend both to emergency department design, but there may be implications that are relevant to those of you that are designing other types of departments that may include the work areas for places like imaging, or may include intensive care, or may even include the nursing and decentralization aspects of acute care departments. So I think that's going to take us to the Q&A. I think it must be back to you, Alan, for a second before the Q&A.
Back to me. Yeah, thank you. Just a couple of quick announcements. Thanks very much, Arsalan and Kirk. Before we get to the Q&A session, I'd like to let everyone know to save the date for the next Research Corner, Ask the Author. On April 19th, our featured author will be Dr. Jabajoti Pati. And then please also be sure to check our events page on the Center's website to see our upcoming events. As you see, there are a number of them. Again, thank you to the Health, Environments, Research, and Design Journal for providing free access to the articles we discuss. Be sure to subscribe to the HERD Journal using the code HERD20 for 20% off. And thanks again to PatCraft for sponsoring our Research Corner Ask the Author events. Now, we reach the good stuff. It's your turn to ask questions of the authors. Please feel free to type in any questions you may have, and we'll try to answer them. Looks like people are already getting started.
So, Alan, I think we'll let you moderate which ones are taken in order.
Sure. So we've got one from Mike Apple. One of the earlier slides stated that one of the results of increased visibility was a reduction in distractions. Can you expand upon this?
Well, that's a very good question. So the audience mentioned that when they see their colleagues and when they have to do some work together, that would support the idea that they can, most probably they can recall that I need to talk to that person about this patient or that issue. Versus in some cases that they have no visibility to each other, and imagine that you would be segregated in some areas, that there is nobody over there to talk to, and then at once when something else come up, then you'll forget that you would have to talk to other person about the patient or information. And overall, this happens in our normal life, but specifically in emergency department, when everything quickly passes and everything would and you have to deal with the patients that are not stable, and you have to just provide healthcare delivery. It's going to be a big issue. So distraction is a big problem in emergency department, and nurses in the interviews mentioned that in this case they can easily talk to each other, and even though something else would come up, again they can recall afterwards to see, oh, that's the person that I have to talk, and that's the thing that I have to recall. So that was what came up in our interviews.
That's an interesting sort of... Go ahead.
Thank you to Mike Apple for asking that question. Mike is one of the authors that Arsalan had in his table where the literature supported or didn't support the material that he was doing.
Yeah, that's a really interesting topic because you've got sort of a balancing act where you've got that nice sort of cognitive cue of seeing the people that you need to interact with, that you're remembering that. And then on the other hand, it's easier for them to find you to interrupt you in the middle of doing something. So kind of an interesting balance there. Gina asks, during your interviews, did participants bring up concerns that privacy and confidentiality might be sacrificed in the EDs that have greater visibility? Were there solutions or behaviors discussed around that?
Kirk, do you want to talk about the answer?
Well, the question is specifically about did you hear any of those during your interviews? But I think sort of the classic model here is that if people are in an emergency, as opposed to non-threatening kind of things that ought to be in fast track, then the sacrifice of a little bit of privacy, not necessarily going too far with it, is understandable so that everyone can instantly respond when someone is going sour or when a problem shows up or when a psych patient begins to act out and threaten staff member. So it's a conscious decision to say that in the emergency setting, and it's similar in the intensive care setting, there are reasons why we are prepared to sacrifice some of that privacy. Well, we also know that you can pull that curtain if you feel like that's not a threat. And so I don't know if any of Arsalan's interview participants actually mentioned any of this. Did you have any conversations with folks?
Yes, I had a very good conversation with them because the scope of our study was about public spaces, about the workstations and the corridors. So we didn't deal with any patient's room. We didn't focus on what's going to happen in the room. So, and also I believe that the major concern about privacy is coming from patient's room. So that was not a big issue. Some of the participants mentioned that, yes, it's going to be an issue if you want to focus on inside, and especially as Kirk mentioned about site patients and trauma patients, since everything is more visible than other rooms. I think it's going to be, as Kirk mentioned, we have to sacrifice a little bit for those type of issues, those type of rooms only. But if you're talking about all the rooms and all the patient rooms, I believe that they mentioned that it was not a big concern. Also, if you just find out our paper about the main study, when we had more participants, I think we got some saturation on that data, that our participants mentioned that how we have to frame visibility versus privacy. And I think I'll be able to send you the manuscript as soon as we could hear from the people about the results. So I think that was published, but that was accepted. But I can send you the publication as soon as I can.
That's great. Thank you. We have two questions from Richard and Shar, both that get to the issue of those confounders that you mentioned. Richard is talking about any observations concerning distance and visibility. A person might have line of sight, but there's no real benefit due to distance. And Shar says you had mentioned acoustics as being key to the effectiveness of the strategy. What are some suggestions you're seeing in optimizing this?
Okay, regarding the first question about the distance, so I should have said that the scope of this study was community ED hospitals. So when we are talking about distance, in other terminology, proximity, yes, in big EDs, it's a problem. But here we only focused on small EDs, which was in between 20 to 30 something rooms. So that was not a big issue in small EDs because proximity is not going to be an issue. But when we are talking about the bigger EDs and bigger departments, of course we have to replicate the findings to see if proximity is going to be an issue, because sometimes for visibility and for teamwork and communication, we have to think about the specific distance for the people to communicate with each other and to focus with each other to see and talk about the benefits of visibility. As far as the safety goes, sometimes it's not a big deal because if they hear something crazy, they can react it easily. And I think proximity is going to be the least of concern for future replication of the study. But if you're talking about the big EDs or big departments, in terms of proximity, I think we have to consider that. But for our study, since it was only focused on community EDs, I think it was not a major concern. Kirk, do you want to expand on this, elaborate this, or not?
Yeah, I would mention not based on what Arsalan found on these studies. As he said, these were small units. But I have other studies, and I've published other material about intensive care settings where the new designs have been more linear and spread out because there has been a reliance on the idea that decentralizing staff close to a couple of patient beds is a good thing, and therefore we don't really need to have this high visibility. And the nurses that work in those units are terrified that they can't see their colleagues, that something can happen and nobody else knows that it's going on, that if there's an adverse event, they're going to be blamed for it. So I think there are some quite serious problems associated with the lack of visibility. And I think the nurses are sharing with me that even though there's a great deal of distance, they still want to be able to see their colleagues so they can wave their arms, so they can somehow signal that I need help, or they can observe when their colleague needs help and respond like that. So I think it's an important issue, and there's potential for much more study here in this particular arena, both in ED and elsewhere.
And to the question of acoustics?
Yeah, I think, Shar, you are talking about the potential for acoustics to be a difficulty that somehow it somehow disturbs the advantage that you're getting from high visibility. So I don't think Arsalan was asked to do that in this particular study, but there are other studies out there that talk about, for example, in a simulation of emergency behavior around a simulation dummy, when the noise level around the sort of background noise is high, then the communication is disrupted. It's not clear. The signal that's leaving the mouth of the person who's asking for help, is not read well in the ear of the person who needs to be assisting. And so if you simply take the implication of that kind of research, what you're hearing is that if the acoustics are poor in this environment, it can make it harder to communicate. Therefore, it diminishes the advantage that you might get with high visibility. So, acoustic control is a good thing wherever you find it in the healthcare arena, right?
Absolutely. A question about the software that you used to measure visibility. I'm guessing I know the answer to this, but I'm not sure, and maybe other people are wondering too. Could it be used equally well on plans before you've built something, or is it something that you can only use on facilities that have already been built?
Yeah, that's a very good question. So think about what's going to be the input of the software. So typically we have to provide the plans, and the plans should be CAD plans or something in different software, which has to provide only the overall layout of the environment. And also we can think about the design alternatives, because the only important thing is the plan with the doors and the windows excluded, and also the major walls and partitions. And during the design process, when you have something went to that level that you have them designed and overall considerations were done, so then we have to run the program to see the visibility levels. So you don't need the actual building, because it's not going to work in actual building. It works only on the plans. So yes, that's a very good thing that we don't have to only use it for post-occupancy evaluation. We have to just do it for pre as well, to understand, to evaluate or assess the plans and layouts to see how they work and how efficient they would be. Yeah, that's a very good question that we should use them in the initial parts of design rather than making all the environment designed and then afterwards having some post-occupancy evaluation.
Fantastic. Now, you've mentioned a couple examples already, but in qualitative studies, you'll often end up getting input that isn't directly tied to your research questions. You're trying to answer some very specific questions about staff visibility, et cetera, but you learned some things about which patients, for instance, they were most interested in having visibility of or visibility around. Were there any other interesting incidental findings that you remember and would like to share?
Well, so first of all, think about the philosophy of qualitative research. And as you mentioned, yes, there are some examples in real life, and they work pretty directly to what we were chasing. But also, we have to think about the methodology, and we have to think about how the ideas were saturated, and we also had a chance to report the things that were repetitive, to think that it's really significant. Some of the ideas were only mentioned once or twice. But as far as the safety, because we just wanted to review the pilot study results and think about the next step, we found that we didn't consider visibility to security personnel for safety issues. And we didn't think that in the literature anybody mentioned about that part in design, and at least in the healthcare design, that visibility to to the security personnel is an important thing. So that ended up in the interviews that the participants, 3 or 4 of them in the pilot study, mentioned that visibility to security personnel is a big deal. And also, we talked to the nurses, and they mentioned their perception of safety is going to be higher if they would understand that other colleagues can see them. So even though they are not trained to control those types of risks, but again, they thought probably if they would be more integrated in the environment, and if they would be more visible to their colleagues, it's way better than being segregated in specific locations and spaces. So that was something that was really interesting for us, and we included that into our second part, into main study questions, and we chased that, and I think we found some results about that.
So, Alan, he's just described how the description that if I can see the security officer, I feel better. Well, think back for a second. His ISOVIST model with the DeathMap software meant that you take the entire plan and you break it into 1-by-1 squares, and then you are examining with the computer what are the sight lines from square X to square Y. So you're looking at the way sight lines can be identified within the physical space. Well, you're talking about from one room to another, or from one space to another. You're not talking about from one space to a security officer who's wandering around. So the security officer is not a tangible, identifiable location. It is a mobile, moving person, and so that can't really be included in the study the way Arsalan originally conceived it. He discovered that there was something he couldn't test with the current methods. So that's an example of something that, that's important. We need to know more about that. But in order to answer that, it's going to take a different kind of study with a sort of different methodology in order to track the ability to see what happens as a security officer is mobile and is influencing the way people within the staff feel more or less secure. I saw him here earlier, but has he abandoned us? Are we with protection now? Or we have confidence that his route will bring him back through here within a few minutes. Whatever. Or that if I shout, he will respond immediately. All those kinds of things can be studied. They're just not part of this one. And as much as we wanted his work to really cover teamwork and communication and security, the truth was it was much more effective to learn about the teamwork and the communication than it was to learn about all of the potential issues associated with security.
And also, we covered the term.
Go ahead, please. We're here to.
I wanted to add one more thing. That another terminology for our visibility exploration was static versus dynamic. So the DevMap software or space syntax just gives us a static idea about the overall visibility level. But also from other side, you can see we had one-on-one, like a face-to-face visibility exploration. And every 20 minutes, I had a chance to have a spreadsheet and fill out that spreadsheet about who can see who. That was something about dynamic visibility levels. And I did that for 12 hours in each site, meaning that we had large data about who can see who. And again, we framed that as dynamic visibility, as Kirk mentioned, that we have to consider the different factors and ideas.
Boy, that must have been a lot to wade through. Another thing that point to that raises is that I think it was Kirk, you mentioned that this study raised a lot of really clear issues for further research, some open questions. Wonder if you could walk us through what some of those open questions are, and And maybe relate them, because you said, this was the pilot study, you've done a follow-on study. Relate those to what your findings have been from that follow-on study and what still remains open.
I think this is a question for Arsalan. His research trajectory includes study of emergency departments and improving the understanding of design of those departments. So he's the one who's looking at what he might do next, or what he wishes somebody else would do.
So that's a very good question. On the second step, on the main study, we also measured the frequency and also the duration of communication among the staff. And also, whatever we found, that most of the studies so far, they talked about visibility, they talk about the overall visibility, meaning they're more it's clear for me that they are talking about face-to-face visibility. What the overall definition of visibility would be about one person can see the other person. But from the other perspective, thinking about the values of DevMap software about overall visibility, we found that some of the factors that space syntax gives you, they are not significant at all. Meaning, for example, some of the factors that we think that, so visibility can be measured differently. So, for example, see if a department would be evenly distributed in terms of level of visibility. So that's one of the factors of visibility. And we found that that's not significant at all. And also it has a negative impact on visibility, because we want to have some places really visible and some places to be ignored, because for teamwork and communication, they are not big issues, because nobody would go there. And also, if we just want to have the whole visibility evenly distributed, we don't have any focal points, any focus points. So that's one of the things that in our main study, we found that contradicts the findings of earlier. And of course, again, our main study, again, in qualitative part, the people mentioned that they mean what they think about face-to-face visibility. They have never thought about those factors as if the department would be evenly provide us visibility or not. So those are some factors that we have to go further. So I think I have to just take all the non-significant factors or the negative related factors to my qualitative study, and again explore and ask those questions as follow-up questions and see, okay, what do you think about those things? Do you think that if the department would be unevenly distributed in terms of visibility would be good or not? So I think it's going to be the next step, but we have to explore. And also, as Kirk mentioned, that many ideas are applicable to other departments, but we should replicate the findings to see if we have the same issue for ICU or not. And you have to consider that we selected ED because in ED everything can be changed pretty fast, and communication can be really challenging. This is why both Dr. Patti and Dr. Hamilton mentioned that Arsalan focus on ED, because there is a probably major concern in communication and teamwork in ED versus ICU or patient unit, that everything is stabilized. At least from this standpoint, we have to figure out how the environment would support communication in this specific department rather than other departments.
That's really interesting.
One of the things, to go back to Gina's question about the privacy, not every part of that depth map needs to turn into red or dark yellow or something. The janitor's closet needs to stay dark blue. and as such, it becomes an object around which your vision is now reduced. So, you don't see through it to what's beyond it. So the arrangement and layout, which is what Arsalan was originally interested in, is then, profoundly affected by how the designer uses this. And I think it goes back to your question about whether you can use this software in the design process. I think absolutely. It's way more important in the design process than it really is in the evaluation process. Or at least, that's the impression of an old guy designer.
Well, we're here to get your impression, so thank you. In your observations, did you note any ways that staff were using workarounds operationally to deal with poor visibility? Were there strategies that they were using to get around defects in the design of their environment?
Well, is it possible to elaborate on that? What was the question again?
Sure. I was asking in your observations of what people were doing, right? The on-site observations. Did you see anything that people were doing to get around the fact that some places had poor visibility, but in those places they wanted better visibility, right? How did they operationalize workarounds for the design not serving them the way they wanted it to?
Very good question. So first of all, I have to just separate the final study and also the pilot study. In the pilot study, I think the site was in a way that they had no enough visibility to the entrance door, and during the busiest hours, they had to just set one of the paramedics to the front door to control the entrance of the people, because they were not easily visible from the main station for them. And that was an issue for them because they mentioned that there are many people they can stick in, and without any understanding that they don't know that how to supervise the whole department. Or also, for example, for communication, they mentioned that in one of the sites for the main study, they had pods. And they mentioned that this pod would be a big issue because during the hours that they don't need both pods, they had some barriers in seeing each other and handling the problems and ideas. And also, I saw some advantages of having visibility to each other as well during my observation, that one of the nurses was dealing with a very sick patient, and they did the CPR, and also I would say 6-7 nurses were involved in the case, plus 2 physicians, and they just consulting with each other and they communicated. And I think in the segregated EDs and in segregated layouts, that could have not happened. And I think I could have seen the ideas of visibility in communication. And also, I can say there was another case that there was a psych patient wanted to harm other patients and other nurses, and I think that visibility helped them a lot to help each other, support each other, call police coming, and they were able to handle the problems.
And I can tell you, not in Arsalan's study, but I have certainly seen situations where people have installed mirrors to be able to see around a corner, or where emergency department was renovated to add a window into a room that previously had not had such a thing. I don't know what you would call it, but things like a baby monitor, there are versions of that where they have put the sound transmission able to be passed out of a space that has low visibility, and so they can at least hear what's going on in that space. So, workarounds are common, and workarounds are frequent, and even when they violate procedure and policy, they're still done because they must be done in order for the care to be given. So nurses are really good at workarounds.
They are the world's foremost problem solvers, I think. I guess we're probably time for our last question. So I'll ask this. Here you've done a study where you were pretty sure you already knew the basic answer, right, at a qualitative level. Could you talk a little bit about the importance of doing research that answers questions that we think we already know the answers to? Because I'm of the mind that it's really important, and I'd like to hear you talk about that.
So that's a question for Kirk, I think.
Well, I think it's replication, where you're duplicating something that has already been done to make sure that it is real, is very important, and many researchers don't do that because they're looking to do something new. And that's a shame. We need more replication. In this case, he was doing an exploratory study because nobody else had done it before. So he was breaking new ground. We think we know what we were going to learn, but there are invariably a bunch of elements, some smaller than others, that came up that said, we didn't know everything we thought we knew. But yes, in the end, we validated something, and what happens is we now take common sense understanding and we enter that into the literature where it begins to build a body of knowledge around the idea so that it advances from common sense to move toward best practice.
Go science. And we have one last question from the audience. Rajvi asks, based on your observation, if the plan can only offer one over the other, what kind of visibility would the staff prefer to choose? Staff-staff visibility or staff-patient visibility? I know that wasn't your central research question in the study, but you did seem to get some data on that on the side. What are your insights there?
Well, that's a very good question. So overall, we have to think about the focus of this study, which was about teamwork, collaborative communication, and security. So of course, in terms of communication and teamwork, it's more important to have a staff-to-staff because we're going to work on those ideas and thoughts together. But when it comes to think about security issues, so we have two considerations. First of all, the perception of the staff. They think that if they would see their colleagues, or also if they will be seen by their colleagues, that would help them to perceive about safety in a good shape, to feel them like they are in a safer place. Versus the idea of overall that, of course, the staff, they don't. Sometimes we have some issues about like the staff conflict, and I've seen some of those in my observations. But overall, in overall cases, staff they hurt each other. So it's more about risk from the audience, from the user occupants, or from the site patients that they would bother the nurses and people. So I would say I can have answer for the first part for communication and teamwork, and definitely staff-to-staff visibility is important, especially for the physicians, because they mentioned that they don't want to be seen by patients and by their families because they don't want to be interrupted, versus in the case that they wanted to see the nurses all the time because they just wanted the nurses to do something for them or undo some comment. I'm not sure what Kirk is going to say about this question.
Oh, I think this is interesting. You discovered staff being important because that's what you were studying. I personally think that if you questioned anybody, they would say staff-patient visibility is most important in the emergency department because their mission statement is to take people who are in distress and who are emergent, and they must do something quickly. Therefore, the ability for the staff to continually see the patients, I think that's understood as the most important, and that the comments you get about staff simply means that they had already assumed that they had to see their patients in order to take care of them. Good question, Rajvi.
For future studies.
Good question, Rajvi. Yeah.
Another former
and we have
student.
to think about, and also we have to think about the philosophy of care delivery. So all the nurses and physicians, they are there to take care of patients, not to communicate. And in this case, especially, we focused on regarding patient communication. We didn't think about like overall communication and like normal day life communication. From the other point, I would say yes. That's the quote from the physicians that they mentioned. They don't want to be seen by the patients, and they just want to go and find the patients whenever they had to. But it's very important for them to find the nurses when they find. So I have to just spread it. So in the final decisions, of course, we have to provide both. But I'm talking about the priorities. So probably it's going to be different for nurses and physicians, as Kirk mentioned. So we have to provide like the care environments appropriate for the whole groups.
Good point.
As usual, the answer is it's more complicated than that. Thanks very much, Arsalan and Kirk, for a really great conversation and for this interesting and thoughtful review of how visibility can influence teamwork, collaborative communication, and security issues in emergency departments. This concludes our event. We'll leave the webinar open for another 15 minutes so that you can download the EDAC and AIA CEU forms. Thanks again, everyone, for joining us, and have a great day.